Such a pleasure to be here with all of you today to tell you a little bit about hospice, and I'll tell you a little bit of who I am and the work that I do, and how the content that I'm presenting to you today is really a culmination of multiple individuals who have put this information together to spread the word about hospice, what hospice care is, and the importance of it, particularly in Latino and Latina families. So I'm Kathy Ramos. I am in the Department of Psychiatry and Behavioral Sciences. I'm a clinical psychologist, but I work specifically in the area of palliative care and hospice care. So I work with a lot of families and a lot of diverse families in this space where it's really about supporting both the patient and family members as they're dealing with and managing serious life-limiting illness. In my time in working in this area, one of the biggest things that has come up is how little the general public knows about what palliative care is and what hospice care is. And in fact, hospice tend to seen the same as palliative care. They're two distinct kind of services. And so I think it's important that as we are having discussions related to our families, what's important to us, in particular, what's important to the family when it comes to end of life care, that everyone is aware of what services are available to them to best support them. So the focus for today is really about what hospice care is, and I'll tell you a little bit also throughout some of my own experiences as a Latina and going through this experience with both my father and grandfather. And so I'll be sprinkling throughout things that I wish I knew at the time, but also just to provide this general education and see if individuals within the Latin 19 network would be interested in having this type of educational material be spread out to the Hispanic serving communities that they serve. We have had this content translated in Spanish as well. So I'm happy to talk a little bit more of that as we go on. So when we think about what hospice care is a medical service that is designed to provide care for individuals who are at the end of their lives. Typically, it's being diagnosed with a serious illness where they have 6 months or less to live. And how we think about hospice care really does drive how we access that support and whether or not individuals get the care that they need at the time that they need it. So hospice care has a palliative care focus. Now, palliative care is for anybody who has a serious life-limiting illness with curative intent. Usually it's for people who, when we think about hospice, it's really to provide them a circumstance where they feel best supported, where their goals of care are being met, but also it's to make the individual as comfortable as possible. And so when we think about hospice care, it's really designed to support and provide care during the last phases of life. It's also an area in the medical specialty that recognizes that dying is a part of the journey. So, dying is a part of living. And the goal here is really on focusing on quality of life for both the patient and the family. So as you can see, palliative care is kind of the larger umbrella, and hospice care is a specific type of service that's offered within that. Just to give you a little bit of hospice history, so here's just a quick timeline of how we come to understand hospice. So back in 1963, we find that Cicely Saunders, she creates the Christopher's Hospice in England. And again, we start to see how over time, and it's been a slow but sort of steady process of how hospice care has come to be and how it is a benefit once we got into the 80s from Medicare. And it isn't until 1993 that we see that hospice is a guaranteed benefit in our healthcare. And by 2004, we find that more than 1 million Americans with life-limiting illness are served by the nation's hospices. So, this service can be really beneficial, again, to improve, quality of life towards those last 6 months of living. But it gets underutilized quite a bit. And part of it is because a lot of people don't know about it. So our goal, again, is to give you some more education. Now, one of the pieces that individuals are unclear about is where hospice care can be offered and provided. So, for example, with my family, when we were approached about hospice care and hospice services, I come from a Colombian and Puerto Rican culture. And with my family, because I know that everyone is very different, within my family, the word hospice meant that we were, trying to rush the process for both my dad and my grandfather as they were struggling with their illness. And the other misconception that they had was that hospice was at the hospital. And so for my family, it's like, we're not letting dad or grandpa die in the hospital. Like, that's not going to happen. That's not what we want. And so in going through those early experiences with my family, it really opened my eyes as to how little knowledge and education there is around not only what hospice care is, which we just talked about, but where it could be offered. And so hospice care can be delivered, as you can see here, across all care settings. Hospice care is provided wherever the individual calls home. So hospice care can be offered privately in one's home. It can be offered in assisted living facility, a skilled nursing facility. There are inpatient hospice houses. We can also see, in different settings, like here, across inpatient units, correctional settings, homeless shelters. So there is a variety of different settings which you can get this service. So again, this is really important to know, because if individuals are under the assumption that it's only in a hospital, for example, they might early on sort of withdraw or not think about seeking that service, where they could have gotten it, in a person's home, which would have been, their preference. So for my family, I know for a fact that had we known then at that time that we could have received hospice care at the home, that would have been a choice that we would have wanted. But that wasn't something that we knew then, and that wasn't something that we asked for or knew more to ask about. And so that wasn't the experience that we went through with my dad or with my grandfather. And so there's also these myths around hospice. So, as I was just sharing how sometimes there is this misperception that hospice takes place in a hospital, there's these additional myths. One, that hospice only lasts 6 months. In fact, if someone, is receiving care and they're doing well, sometimes people have gone out of hospice, for example, if they start to bounce back and do well. Another is that hospice is giving up, or that they're going there to die. And it's not about giving up. It's also not to be in a position or in a place where they're just left to die. It's really about, how do we enhance their quality of life with the time that they have? Hospice, another myth is that hospice is there to give the patient morphine to die, and that's also not the case. So it's not about putting someone in a hospital bed and just give them morphine and wait until they pass. In fact, there's always a nurse. There's someone there alongside the family to help them be as supportive as they can to their loved one. The other is that it's the doctor's responsibility to bring up hospice. And I think this is a really big one. Within my family and my culture, it was very much like, we do what the doctors tell us. And I wish at that point also we knew that how we could better advocate for ourselves and advocate for the health and care of my dad and my grandfather. And so you, as a family member, or if you yourself are going through the experience of having a chronic or serious illness, you can bring these questions up to your providers. And in fact, we encourage you to do that. Because again, depending on who your provider is, sometimes they themselves might not know too much about palliative care or hospice care services that are available in the area. And so when we bring that information up early, and we can start having questions and discussions about what's in the best care of our loved one, the outcomes tend to be much better in terms of how we're improving and supporting quality of life. Another is that once you're in hospice, there's no turning back. In seeing patients myself, I've had patients who've been in hospice, and because of the quality of care they're getting, they actually were doing so well that in some of these circumstances, and they are unique, it's not for everyone, but in these unique circumstances, they were able to move out of hospice, and live with their, keep living and doing what was most important to them for some additional time before their passing. So, again, hospice care is really designed to be a service to provide support, but it doesn't mean that, one is giving up, or that once you're in hospice that things might not change. The other is that if you choose hospice care, you won't get any other medical type of care, and that's also untrue. So hospice is an added layer of care that you're getting in addition to the other care that you're being provided by other medical specialties. So when we think about hospice and hospice care and its services, who delivers them and can we trust them? And again, this was a big piece for my family, where my family was very mistrustful of the providers because they felt that they were getting mixed messaging from different providers related to both my father and my grandfather's care. And I think part of the mistrust also comes from miscommunication, when there aren't clear lines of communication between what the families need, what they're trying to do that's in the best interest of the patient, and how that information gets communicated with the providers. And then also how the providers are talking with each other and talking with the families. So what's important here is that we need to build more awareness of who is involved, who's the team, and then also how can we improve the lines of communication so that we can build that trust in that care. So in terms of the folks involved, as you can see here, the patient and the family are central to receiving care from physicians. There's counselors that are involved, there's nurses, there's home health aides, there can be chaplaincies. So, in my family, religion and spirituality is critically important. And so, having had access to chaplaincy and spiritual support in that way would have been huge. There's also homemakers and volunteers, as well as social workers, to really support just the care and the well-being of both the patient and the family. And what this team does, which I think is really critical, is that this whole team collectively, we're talking about how we can develop a good plan of care for the patient. We have discussions related to how to manage pain, how to manage symptoms. Also, there's lots of discussions of how to attend to emotional, psychosocial, and spiritual concerns that come up from, dying, and also that come up from caregiving. It's also about teaching the family how to provide care in this circumstance. Also, we have discussions of how to best advocate for the patient and the family. And then when that time does come, when our loved one has passed, the ways in which our family members can receive bereavement care and counseling. So here with we'll go through each one in particular. So with the physicians or the medical director, they're overseeing and reviewing the medical services that the patient is receiving. So they tend to meet every couple of, sometimes twice a week with a team, just to see what is the care that the patient is receiving, how is the patient doing. They're currently, working with who's the first doctor to recommend hospice, and then, they do consults regularly on the patient's care, how they can help when there are medical challenges. They also are really good at helping calibrate changing medications based on the changing needs of the patient. So if there are changes in their health, the doctor is there to sort of help calibrate and also get specific direct feedback from the full hospice team and caregivers as to what the patient needs. And then of course they review all changes to the patient care. And so that's the main overall role of the physicians. When we think of nurses, in their role, they're serving almost as a central case manager. They're integrating, they're following through that hospice plan of care that's been discussed between the providers and the family. They perform weekly assessments that can focus on symptom management and comfort care. They're also teaching both the patient and the family about physical comfort measures. They ensure that the patient's orders reflect the plan. They document any patient progress in the facility. They're constantly communicating with the family for updates and education and additional support. And they're also collaborating and communicating with the team. So they serve really nicely as a liaison between the patient, family, and the physicians. And then aside from that, we also have home health aides. So these home health aides are primarily paid through the Medicare home health benefit. They can also be paid through general health insurance or private pay. And the purpose here is to provide supportive care in the home. So usually you'll have a licensed healthcare professional and professional caregiver who will provide medical care needs or daily assistance to help the individual ambulate. With my dad, before he was eligible for hospice, we did have a home health aide that would come and help with like feeding, that would come and help with dressing and bathing. And so these are really similar types of services that the home health aide can provide to the family in this kind of circumstance. They can also, offer, just additional care with like preparing meals, helping clean the home, and also supporting the caregivers and the family members that are needing it. It's important to note that, within hospice, it doesn't necessarily mean that they're getting 24/7 bedside care, but the home health aides are coming typically anywhere between like 4 to 8 hours a day to provide assistance. And then we have social workers. And this can be social workers or psychologists where they're providing counseling and support for patient and the family and significant others. They're really there to help support the patient and the family process what's happening, to answer any questions, from an emotional standpoint and from a well-being standpoint. They're assisting patients and family with identifying services and benefits that can also help them related to financial resource information. They also spend a great deal of time to have discussions about their life, and we call that life review. So really helping and assisting patients and families in this really difficult time, and help them find meaning in what they're going through. They also can attend family meetings and care plan meetings as appropriate. And in addition, they can provide really important discussions related to end of life discussions and planning. And so these are individuals that have tremendous amount of resources available to them that, again, it's really there designed to help support individuals. And then we also have counselors, and counselors are a specialized group of social workers who provide counseling to patients and family members across other types of concerns. So for example, if there's family disagreements or family dynamics in terms of what's the best course of action for the family member, they can help with that. They can also help provide grief support, provide counseling for young children. So in my family, I had some pretty young nephews that weren't understanding what was going on, in particular when my grandfather was dying. And so being able to access support from counselors that have the language and know how to talk to family members across different ages and where they are developmentally can be really helpful. And then also, what's nice about with counseling services is that it can be provided across different settings. And it's also available the entire time that the patient is in hospice, and up to 13 months later. So in my case, after my dad passed away, I was offered grief counseling for almost a little over a year after his passing, which was a really nice benefit. Now, there's also chaplains, and chaplains can provide spiritual support to patient and families. They can help with final arrangements. They can provide pastoral care and counseling, also provide emotional support. They can coordinate with your family minister, for example, or a rabbi or a priest, based on your religion. And they can also offer comfort, prayer and scripture reading, and offer sacraments, during this time. And they can also help overall with funeral services. So in my situation with my dad, for example, when he was, it was very clear that he was going to pass very soon, we did have chaplaincy come and just give a blessing to my dad. And even though this individual was not, our pastor, I know that it was of comfort for my dad to be able to receive that spiritual connection that he needed. And it also gave us a lot of peace of mind that, given how important religion and spirituality was for my dad, that there was this individual that could provide that care and that support in that moment in time. And then volunteers are wonderful human beings in this care. They volunteers provide additional emotional support. They can read to the patient, provide comfort, help with any correspondence. They can also be there to just give the caregivers and the family members just a minute of time so that they can go do things for themselves. They really provide a caring presence. There's a dog there, so there are dogs in hospice as well. I personally trained my dog to be a therapy dog, so before the pandemic, we would go and visit patients and families. And it's a tremendous amount of comfort that can be provided by these volunteers, and also by these trained dogs. And volunteers are people with huge hearts. They're willing to give of themselves. These are individuals of all ages, all backgrounds, who share their time and bring their own individual interests and skills and talents to hospice. And so there's many individuals that, again, you can receive additional support from. Now, almost everyone is hesitant to try hospice. Part of that is because it means that we're having discussions about death. In our society, across different cultures, talking about death and dying is very much taboo. It's not something that gets discussed. And it's unfortunate that these discussions aren't had more often and aren't normalized, because, again, death is a part of life. And the more we can have discussions about how we want our time to count and matter when we are reaching the end, the more we can really benefit of the quality of life that we're having. And here are just those additional reasons. It's a scary topic to talk about. It's completely understandable. A lot of people don't want to focus on the difficult or challenging parts, and it is. It's a very hard time, but it can also be a very meaningful and beautiful one. The decisions needed are tough ones, and they are. Sometimes, depending on the health status of your loved one, they might not always be able to communicate what they want. I know that was a large or a huge regret from my family, with my grandfather in particular, was that in their efforts in trying to keep my grandfather away from hospice, there weren't enough discussions, or at least timely discussions, about what his wishes were. And so there was many different opinions about that, what that would be. And there was a lot of regret after his passing related to that. Where there's also hesitancy because we don't want to lose our loved ones. And that's a very real concern. And it's to the extent that we can have very frank and honest conversations about, if this is, their time, what can we do to make that time count? What can we do to respect their wishes and what's most important to them? And the process is not an easy one. It can sometimes feel confusing and like a roller coaster. And that's why we're really wanting to help demystify and clarify what this service is, what this process can provide. Because I do feel that as individuals, the more information, resources, and education that we have, the better we can make decisions for our family and loved ones under these circumstances. And, hope and faith can help. So, again, there's chaplains and chapel services. There's, the primary caregiver role and comfort and love throughout this journey. There can be a tremendous amount of companionship and community that is built throughout this process. And so, the piece here is, particularly with Latin families, we are now nearing almost, a significant representation across the United States. And yet we as a community tend to underutilize these services. And a lot of it is because we don't know what this service is or how it can help. And, if you look overall across the United States, across all communities, about 70%, 75% still don't know what this service is or what it can offer, even though their families really stand to benefit. So again, we're really trying to support this work and also support this level of education so that families and patients can make the best decision they can for themselves. These are just some questions that when we are meeting with families and communities, we ask them to hear about their stories. So our goal is to try to disseminate, try to exchange this information and present to Hispanic communities. And so these are the types of questions that we also bring up because we want to make sure that we're understanding an individual's experience and how that has shaped their own understanding of hospice. So these are types of discussion questions that we have for them of like, how did they receive the news? Did they get a clear understanding? How did they feel about it? How did the rest of the family find out? Did others help? And what did that look like? Because the more we can have a conversation with each other in our community, I think the better we'll be in understanding, what we know about what hospice is versus what we don't know, and also how we can help, again, demystify some of these myths. And then we also want to know from the people we talk about how they've handled bad or difficult news in the past, and how all of these elements, like hope and faith and love and community, all of that really helps how to come together and deal with the challenges that come their way. So the goal for us today really is to just talk to everybody a little bit about what what we do, what hospice is, to try to educate individuals as best possible. So if there are those of you on the call that think that this type of information and education would be important, which of course I'm biased, it's relevant for all of us, but if we can present it and we can present it in Spanish, and we have content in Spanish, but really present it and get it out there, our goal really is that we can help improve the way that our Latin and Hispanic community are getting quality care, and that for those that are going through that experience of end of life, that they're receiving quality of life in those moments. So here are just some additional information if people are interested. This is the info. We have some terms that people can see. These are the different organizations related to hospice. And then here are just the different contributors to this work, which of course we're just so grateful for. So I'll stop it there and ask if anybody has any questions, but I do appreciate your time in having this conversation with you all.
Thank you, Dr. Ramos. This is such a wonderful, and this is so important to share this information. As you said, we are I'm from Colombia too, and there is a lot of myths and fears about getting to that point. So I have a few questions. Is in your services, how much available bilingual services are? I know I have heard that sometimes one of the barriers is that there is no great communications and no services that can be provided in Spanish. And the second question is how accessible is for people who are uninsured or that they don't have Medicaid or they don't have any private insurance.
Yes, I'm happy to answer both, and I have more information for the first question than I do so for the second, but I'm happy to get more information and share that and distribute to you all. So in terms of bilingual services, so an example here at Duke is we do have a translation services that are available, translator services. So we have translators who speak Spanish, and can provide care. It doesn't hurt, for example, to ask if you have bilingual providers. And sometimes that might mean that the medical provider may not be bilingual, but someone else on the team is, and that can help facilitate and liaise questions and concerns. So for example, in my work with other patients in the space of palliative and hospice, like when I'm seeing patients for mental health support, I'm also I'm bilingual, so I can provide services in Spanish. But the other thing that we can do also is help come up with questions to be able to ask the providers of what's important. So there are if the provider isn't bilingual, there is a service within Duke where we can offer translation and translators that can be there during the meeting, when you're meeting with the providers, when you're meeting with the other healthcare workers and having these discussions. So yes, they are available. And then in terms of information regarding individuals for uninsured, there are different ways in which those that are uninsured can receive hospice care services. It does vary. I know that in some hospice like homes, so these are they're separate from the hospital. They can do like sliding scale, so based on income, they help really support services for you, and there are also different resources within the community to sort of work with families who do not have the finances to get this service, but to support them. So whether it's through donations, whether it's through like a charity care eligibility process, there's that also. So it's really about asking those questions, but I'm happy to kind of put together some information if individuals on this call are interested and disseminate that.
Thank you so much.
Yeah.
We have a few questions in the chat, and then
Sure.
let's answer that from Kirsten Ingram. I know that she's having some trouble with her connectivity.
Okay.
Are you, Kirsten, still there? If she can read the question, if not, we can see it in the chat.
Yes, I'm seeing. Yeah, so the question is, in the event that the patient is receiving hospice care in their home and the patient is about to transition, what should the family do? If they call the hospice nurse on call, can the nurse do a home visit so they can transition comfortably? Also, when should the comfort kit be administered, as well as who should administer the kit? So yes, I think this is a really great question. Yes, the first point is if an individual or patient is receiving hospice at home, the first thing I tell families to do is to make your call list. So these are important discussions that you should be having. So you would have the, with the hospice nurse, she's going to be the first person you want to contact and you want to reach to. But what I tell people all the time is, on a sheet of paper, just write out, put it on your fridge. Who do I need to contact for this question? Who do I need to contact, if something changes, if if my loved one is ready to transition or transition, let's say overnight, who do I call first? It's important that you have those individuals identified and you can identify them early so that you know who to call. And then also, what who's available to provide additional support. So sometimes teams, even though the service is the same, work a little bit differently, not too differently, but sometimes like just the point of contacts can change. It's going to be really important that the family has that information from the very beginning, and that they're also constantly asking the like home nurse in this particular case, like if anything has changed in terms of who they need to reach out to and when. So it's always going to be, I think the challenge honestly is making sure that communication is clear at all times. This is a really difficult and overwhelming period in everyone's life, both for the family and the patient. And I think sometimes in that sense of being overwhelmed, also being anxious and feeling upset and sad about this circumstance, that it can be really difficult to sort of shift your gear and start talking to providers, or look at all of the information that you need. So to the extent that you and your family can support one another on communicating often and clearly, and also asking the same from the providers, and having that information like legitimately on a piece of paper, or I saved all of my dad and my grandfather's contacts on my phone. So I knew right away if someone was calling me, which doctor was who and who I needed to talk to. So I hope that information is helpful.
Hey, Kathy.
Yeah.
Kathy, it's Steve.
Hey,
a long
Steve.
time. How are you? I'm a long time hospice volunteer, 8 years. In this circumstance that the question about, it's almost always the hospice nurse who comes out and says, yes, you're right, they are in transition. And then some really good discussion about how it will go. There's a basic premise here at hospice, which is no one dies alone. And so we have trained volunteers. I have done this, who will sit vigil with your loved one if you need a break, or whoever's with them, needs to go do something, because in that last few days, 1, 2, 3 days of transition, it's a 24-hour challenge. And sometimes, family needs a break. So we have trained volunteers who will spell the family, and they set up shifts for the volunteers, and they go and they sit with the patient, the loved one for 4 hours, and then the next volunteer comes, and so on. But all of that information, and if there is a trusted person at home that the patient, the loved one agreed, and hospice agreed that they are okay to be administering, things that are needed, anti-anxiety, because often at the end, there's some anxiety for, the loved one about, hey, this is happening, even if they can't articulate it, but they can listen, and so they're there, right? We know that they are there, and it's a very, very precious time. My description, having done it a number of times, is that the only other thing in life that is similar to being present when someone passes, for me, was being present when my 3 children were born. It is equally as sacred. It is equally as important to have all the support needed, medical, psychological, and social, all 3 things, and to have family involved. It's just critically important, and that's what hospice tries to do.
Oh, beautiful. Thank you so much.
You bet.
Claudia has a question. Claudia Ramirez.
Yeah, hi, thank you so much for this topic. Quick question, in the case of home hospice, a lot of family members end up carrying out tasks that are similar to what home health aide would do. Is there a way for those family members to get financial compensation for their tasks and their involvement?
Steve, do you know about that? Because that is one that I am not fully clear about, and I don't want to speak out of turn, but I'm happy to find that information as well.
I'm trying to think if I ever knew of a situation similar. And the payment, for anybody who's over 65, Medicare is paying, right? So they would need to be a contractor. I'm sure that if with enough planning ahead of time that something could be arranged for somebody who's really good at it to be contracted as a provider, because the funding comes to hospice.
That's right. And my understanding also is that in those kinds of circumstances, even working with the social worker, because they have a lot of resources and information about what that process is and what that looks like, that would be your main source of contact of, just identifying, hey, I'm spending X amount of time and caring for my loved one, and here are all the activities that I'm engaging in, and they can also be a valuable resource in getting you that information, and then any documentation that needs to be provided for that. I hope that helps, Claudia.
Yep, thank you.
Luisa?
Thank you. I guess following up on Claudia's question, are there not like agencies, like home health care agencies, that agree to like process and enroll a family member that's already doing the work? Because I've already like heard of this model before, so I'm surprised that it would be, like having to do a private contractor thing, because I don't think it was here, but I remember seeing like advertising of like people saying like, I'd rather, my sister or my family member give me my care, and like information on how the family member that's already providing this care could like enroll and go through the same process. Is there not like an equivalent of that in the state?
So I know that there is variation from state to state, but my understanding is that there is what's called a home and community-based services program, and through there that particular program is where you're identifying whether it's a family member or a friend, for example, that is helping with daily activities related to like ambulation, eating, and you can enroll in that. So I know that some organizations facilitate that process for the family member, but also individuals can look up that home base. It's called Home and Community-Based Services Program, and you can look up at that program and then follow sort of like the requirements and process. So it's a kind of a different ways to get connected, whether it's through an agency and enrolling, or you looking yourself up that specific program and identifying what can be offered.
Wonderful. More questions? There is a question about how we can have access to the PowerPoint presentation. And I know, Gabby, please, can you confirm that it will be available in our website and in the newsletter?
So depending on the preference of the presenters, we're able to make those available. So we can connect with Dr. Ramos after this and check in on that and figure out what the best way for everyone to access it is. And we'll put it in the newsletter. So if you're not on the newsletter, make sure you sign up.
Good. Eric, you have a comment? And also Mary Jo. Sorry, we can go with Mary Jo first and then Eric.
So I don't know that I really need to explain anymore, but I worked with hospice in Savannah, Georgia, and both in Winston-Salem, North Carolina. And during both of those times, it's been a few years ago, but we did not have a policy by which we were able to have families to be paid. It was just a volunteer basis type thing.
Okay.
Yeah, my understanding is it can be pretty variable. So I think that Mary Jo, to your point, I think one of the things that I really try to instill in all families is just be aware what's available within your home state and like in your immediate community, because it might not necessarily be the same. So my dad and my grandfather both passed in Florida, and our approach there was, looked differently than like what I have seen here when my mother-in-law, for example, passed away from breast cancer. So it can be variable. So that's why, is to the extent that again, in this really difficult moment in time, you can get as much information as possible. That's going to be critical. But identifying the, and asking, and it's in your right, it's in everyone's right to ask, who is the social worker, who can help me, who can provide services, or who's a bilingual provider or translation services. Like, we definitely want to advocate for you to advocate for yourself in that regard.
Good. Eric had a very good question. Eric?
Yeah, so I mean, I was just wondering if there has ever been a role that has been explored, or if that's something that that in terms of helping kind of bridge that cultural understanding, and also just being as a source of support, even if not in hospice, but in the community, and what might and what would that look like? And is that something that that has been explored locally?
So I think from I'm a researcher also. I will say from a research perspective, there has been great interest in that. So how do we work with individuals within local communities, whether it's through community health workers, individuals that work in Spanish serving healthcare agencies, how do we train them to have this information and either be a facilitator or even like a cultural liaison about these types of questions. Now, has it been implemented? I think, Eric, that really gets to your question of like, do we have a system or a model that's, that can be followed? And not one that I have seen. And honestly, I think it would be tremendous to start that process of being able to work with different individuals in the community to see how this could be done. I think one of the barriers that comes up is, just additional funding and financial support of individuals that are doing this work, right? Because the last thing we want to do is to add on more work to individuals without, them getting the proper compensation for their time and, and energy. And so I think that's where there's, we're in this process of like seeing how, researchers are trying to see how can we implement this, but also like what would, how people can be properly compensated for this. But I think it's a great idea.
If I could just sort of follow up on that a little bit, because it seems that, you make a really great point in terms of the funding, and it seems that for this this type of work, it really does come back down to private and public payers, right? Like individual payers. This isn't something that necessarily would come from a grant, and if it was, it would be a very time limited type of thing. So I think that that's where, that it seems like it would be a very sustainable model if we could, if health insurance and public and private would cover community health worker time for this type of work.
Yeah, and I think, to the extent that I know at least within Duke that there has been a significant push of like how providers and researchers can work within the community to even look at, what could be sustainable funding, right? So not time limited funding, but sustainable funding that can be accessed to help support the local community and local community leaders to be able to provide this service. So I'm happy to talk to folks and see. This as Marianne has shared, this, I really believe in this work. I really believe in like the importance of getting people connected. A lot of this information and education that we offer, we're doing this as on our own voluntary basis, independent of like our own research and work. But I'm really happy to be able to connect with folks who are interested and try to see like how we can help, because I do think it's important, and I do think that families and all individuals are worthy of getting this kind of care, because it is critical. I think it is important. But I really appreciate your comments, Eric.
Thank you so much. I mean, again, we continue enhancing our education to the community, and this is a very important topic to really demystify the process of hospice, of to have those hard conversations.
Yeah, and happy to connect with folks offline if you're interested. Happy to have more conversations. Thank you for truly, it's such a privilege to be here on this call and to be able to talk with all of you. So I sincerely appreciate your time and your questions.
Thank you so much. Gabby, any announcements?
Yeah, I had a follow-up question, Dr. Ramos, and for others who've done this, I think one of the themes that we hear on this call when important conversations like this come up is the necessity, at least in our community, to hear about a lot of this in person, right? We talk about it with COVID vaccines. And so I'm curious if you all know if this kind of thing is hosted at health fairs. Like, I'm just thinking, you know, you have your blood pressure booth and your diabetes booth. Like, does anybody ever do sort of an end of life booth to have conversations about this? Because that seems like the real in-person place where you could at least plant the seed, and then you've heard of it, and then in the hospital it happened. Do you know if anybody is doing that?
It's really rare. You can share some more. It's really rare, but I love that idea. You know, I've done some of that when I lived in Houston, where we would, to your point, we would go to health fairs. We would go to, I would go on a Friday night, I would go to bingo night, and, you know, church communities would have like dances and stuff. And I would sit there, you know, and not to create or bring a dark cloud, but just to highlight, like, you know, this is a very important aspect of everyone's life that does not get discussed. And if we can start having a conversation now and early, what a gift that is, that we can then work with our family and say, this is what's important to me. This is how I want things to be. So when you do get to that point of having to say your goodbyes, you know, you feel like you are more present, that you are more connected, you know, versus dealing with all the stressors of who do I talk to and what do I have to do. So I love doing that. And I'm happy to, you know, volunteer my time also to help out whenever possible, to go to health fair. I mean, I love doing that stuff. You know, talking to church communities.
Right?
Yes, absolutely.
If a health fair is about the spectrum of life, then
of the whole health, that's right.
Right. Then having something like this there more and more, again, normalizes it. And I'm looking to see who on the call is here from our community groups. Eric, I see you. I wonder if this is something that you know, has a potential to be discussed at some of the stuff El Centro does. Not sure who else is here, but, you know, could we consider thinking about having an end of life kind of stand or booth or puesto at some of the awesome activities that you all do?
It's something that is that's possible. I'm going to let see that Emilia has her hand up, so I'm going to yield that to Emilia.
Hi,
and I'll follow up if there's.
Yes, thank you. I'm gonna take on that question. I am the manager for civic and community participation at El Centro, and we have an aging initiative. And we have actually been taking some trainings on difficult conversations, hospice, palliative care. So we have started these conversations, and we are planning on moving this initiative towards working with a larger group of community health workers, because of the importance of not so much language, but the cultural sensibility, but the trust that needs to be constructed in order to have these conversations. So yeah, we're looking to continue to expand our training, but definitely something that we have already started working on. So we're definitely interested in gathering more resources and support and expanding the network in that direction.
Thank you, Emily. We have Mary Jo, the last question, and I know that the time is up, but I think we can extend a few more minutes.
Thank you. The Hispanic League, at our annual fiesta, we have a healthy living area. And so we've often had Hospice and Palliative Care Center, which is now called Trellis, here in our community, to have a booth there to share information. It would be more so just to make people aware of the services that they provide versus, actually having a counseling session or something like that. But our community service coordinator, Jennifer, is aware that for families who need counseling, grief counseling, they're available free of charge. They do 6 sessions locally. And the person does not have to have had a family member who went through hospice. It could be a car accident or any number of different things. And they also have a camp carousel in the summertime for children who have had a parent or someone who is on their behalf. So, thanks.
Thank you. Okay, so thank you so much, everybody. And Gabby posted what we are having next week. So Gabby, you want to explain?
Yeah, thanks everybody. This is obviously not a one-time or two-time conversation. Thanks, Dr. Ramos and everybody. A few weeks ago, we talked about pediatric obesity because one of our colleagues came to share the Bull City Fit program looking for, and so wanted to share that because everybody wanted to come and talk about it next week. We will have the whole session dedicated to this.
Good.
So tune in next week. Thank you.
Thank you, Gabby. I know that Alex is asking a question. Before we leave, Alex,
yes.
are you there?
Yes, my question is, in all these services include Latinos people over 65. Yeah, but many people don't have Social Security.
Kathy, you want to answer?
Yeah, so so these services that are available, it can, it's based on the type of insurance you have. So even if you have private, public health insurance, so it is available for all people because hospice is also even delivered to children. So it's for individuals across all ages. So it just depends on who you're working with. If you don't have insurance, then there's other ways in which there's resources in the community to sort of help with the costs associated with receiving that care. And I'm happy to get more information for you, Alex, if you want to shoot me an email and stuff. I'm happy to help.